Hello, I am Dr. Deepak Padmanabhan, and I am from Narayan Hrudayalaya, Bangalore. I have been given this opportunity to present the approach to and outcomes of ablation in patients with inflammatory cardiomyopathy. These are my disclosures. The questions essentially are mainly to deal with whether VT ablation in inflammatory cardiomyopathy has a stable, well-defined circuit, whether it has bipolar ablation that is needed, whether the best outcomes are observed when PET scans show active inflammation, or if recurrence rates are lower when inflammation has subsided. Most of the times, the recurrence rates are lower when inflammation has subsided. We should look at the data regarding the same. Similarly, the setting of VT ablation in inflammatory cardiomyopathy, the presence of equal SQRS intervals at endocardial and epicardial sites, a high amplitude unipolar signal with preserved bipolar voltage, and a PPI TCL difference of greater than 30 milliseconds at the epicardial site do not suggest the need for bipolar ablation. It is a significant decrement during programmed stimulation at a deep septal site that suggests this. So looking at these two important questions in inflammatory cardiomyopathy, the objectives of my talk are essentially to help you understand the arrhythmogenic substrate in inflammatory cardiomyopathy, review the approach in ventricular arrhythmias, examine the outcomes based on inflammatory activity, and explore the ablation of atrial arrhythmias in this pathology. Inflammatory cardiomyopathy, at the very least, includes cardiac sarcoid, tuberculosis, and a combination of two. Both of it is present in these common tropical areas and even in the non-tropical regions. Granulomatous inflammation leads to scarring, which in turn forms substrate for VT and atrial arrhythmias. The pathophysiology of ventricular arrhythmias is mainly because of reentrant VT from patchy scarring. Active inflammation can trigger focal VTs, and basal septal fibrosis is commonly involved in these patients. The approach mainly has got a bunch of stuff to be done before taking these patients up for ablation, assess the need for ablation, and look at what is to be done once these patients are ablated. How do you manage them? So understanding the substrate by use of both the cardiac MRI and the FDG PET, the cardiac MRI predominantly for fibrosis and the FDG PET to document active inflammation. Then an electrophysiological study to assess VT inducibility once the patient is not in the acute stage. And finally, evaluate the need for immunosuppression. Which investigation to choose remains a challenge, and it's often related to the stage of the disease that we are in. The FDG PET uptake is very high in the initial phases where the CMR may just show hyperperfusion, whereas the CMR may be more valuable when there is debris in the extracellular space with diffuse fibrosis and remodeling. So the inflammatory stage, early stages, the PET is useful. In later stages, the MRI might be more valuable. The MRI findings commonly suggest hilar lymphadenopathy and multiple liver lesions occasionally. The STIR in these patients shows edema of the basal septum and RV insertion points in the acute phase, whereas in the chronic phase, you may not be able to see it. It is mainly RV insertion site fibrosis with involvement of the RV side of the septum, which gives you a poorer outcome. There is also the presence of diffuse myocardial edema involving the basal septum and diffuse myocardial to subepicardial enhancement in the basal cavity also. The four-chamber and the short axis cine images show severe hypokinesis of the basal septum with global hypokinesia. Additionally, you will also see that in the presence or of acute inflammation, there will be focal edema or generalized edema on STIR imaging. But in the chronic stage of the disease, edema on STIR imaging is absent. You will have focal epimyocardial enhancement of the basal or the mid septum. Compare that to the presence of PET in the early stages where there is PET positivity that is very, very well seen. It is seen both in the myocardium as well as in the lymph nodes. And it is common to present the PET as a prognostic indicator where abnormal perfusion and FDG definitely shows survival free of death, which is much lower than a normal perfusion and absence of FDG uptake. The RV FDG uptake is also similarly very prognostic, where the absence of RV uptake is selective for a bunch of patients who are likely to live longer. The PET scan sensitivity and specificity pooled is approximately 89% sensitivity and a pooled specificity of 78% for the diagnosis of inflammatory cardiomyopathy. In acute stages, especially in patients with VT storm, where PET preparation may be a challenge, use of the Dotanox scan, which is a single stage scan useful in critical patients and less affected by dietary preparations, is very useful. In inflammatory cardiomyopathy, therefore, it is useful to detect early cardiac involvement. It is useful to select a site for biopsy, and it's also useful to assess response to therapy. Now, comparing both the PET and the MRI for early inflammatory cardiomyopathy, the more probability is present for the diagnosed fibrotic stages of the disease with the MRI, higher septal disease detection as compared to PET. But the PET is always positive in 100% of cases when there is early cardiomyopathy, and there is better detection of disease activity in lymph nodes, which could be potential sites of biopsy as compared to the MRI. When considering approach to ablation, the general principle is ablate only when necessary. Ablate when there is no inflammation, and the aim has to be to ablate to ablate using a substrate-based selection. Epicardial access should be considered when necessary, especially if the imaging shows epicardial enhancement or fibrosis. The strategy for ablation using radio frequency is to do an electroanatomic map in sinus rhythm, target the low voltage zones, late potentials, and also address the deep intramural and epicardial circuits. Now, if you are looking at bipolar ablation, we have to ensure that there is a delay in the deep septal substrate by at least 40 milliseconds to use bipolar at these locations. The technical considerations are challenging, especially because most of these VTs are multiple, they are hemodynamically unstable. So a substrate approach is better as compared to mapping the ventricular arrhythmia. 50% of cases require an epicardial access. And if there is need to ablate when there is active inflammation, it is best to avoid ablation near active granulomas to avoid the risk of flare-ups. Now, these are some common signals that you can see when you're ablating. On the endocardial site, when there is an ongoing VT, if you try to perform entrainment during the VT, you will have two sets of signals, only one of which might actually get entrained. But if you look at additional sites which may be present on the epicardium, you may be able to capture these very signals and also keep on mapping and have majority of the circuits at these locations where you may have the entire diastolic corridor as shown before and the pre exit site or the site just very close to the exit of the ventricular arrhythmia in the epicardial location. Sometimes the VT is unmappable, either because of hemodynamic compromise or because of ill-sustained VTs. In these patients, ablation of abnormal substrate EGMs are very critical, where we are looking at ablation of areas of DCT in LV septal regions where the delay is more than 40 milliseconds, independent of their participation in VT. But we have to be very careful that these delayed areas of activation have to spare the conduction system, and we have to always look for conduction system access here. So if you do only the VT ablation versus VT ablation and the deep septal ablation by diagnosing these locations, you are likely to have better success. Bipolar voltage assessment characteristics are very challenging, especially in these patients, because a lot of the scar is amidst areas of high voltage activity, where a 3D anatomical mapping system might actually pick up the largest signal for assessment of voltage, and therefore you may require uh, special techniques like the DEEP technique or the S3 technique to be able to document these areas of fractionation. And ablating and mapping using the DEEP technique might actually be of value where decrement is actually documented and we are able to ablate these sites better. Sometimes use of a good 12 lead holter, especially in the acute stage where a PVC might trigger off ventricular fibrillation, can be crucial, and use of mapping and especially intracardiac echo might be useful to document these arrhythmias which arise from a fascicular location. Now, in the acute stage in VT storm, it is probably better to perform the denervation bilaterally prior to going in for an ablative approach. And here it is the uh, cervical sympathectomy with division of the nerve of Kunz whenever present, the left followed by right, and documentation of the histological analysis of neurological tissue after the excision of the cervical ganglial chain might be very valuable. Acute outcomes 70 to 80% when you're ablating for VT, 30 to 60% recur over 1 year. Multiple procedures are often needed, and there is a significant reduction in ICD shocks, but at the cost of increasing number of ablations. Higher recurrence rates are seen with lower complete success if you ablate during active stages. More unstable VT circuits with poorly defined substrate and dynamic substrates are present, and immunosuppression in these patients for at least a day or two should precede ablation. Cases of myocarditis where VT ablation was performed and you had endomyocardial biopsy proven myocarditis, you can actually document that the independent risk factors for VT recurrence include the stages of acute myocarditis. Outcomes during acute inflammation in a series by Dr. Seontis et al. Similarly showed that inflammation was a poor prognostic factor. Once inflammation has subsided, you get a lower recurrence. 25 to 30% of these patients only recur, and there's a stable scar allowing for precise substrate modification, especially when there is a PET negative status. In TB myocarditis, one of my colleagues presented recently at Heart Rhythm Society. Similar success values can be achieved, especially if it is not present in the acute stage of the disease. Adjunctive therapy like corticosteroids and methotrexate, anti-tubercular therapy, immunosuppressive therapy to stabilize the substrate are very valuable, and ICD implantation is always recommended in the non-storm period of the disease. Now, there is a new molecule or a new test called the serum chitotriosidase, which is being of increasing value and is under investigation in inflammatory cardiomyopathy. This is an enzyme secreted by activated macrophages. The elevated levels indicate ongoing granulomatous inflammation. It could be useful in sarcoidosis to monitor disease activity, especially if the correlation with PET activity and relapse risk can be more clearly delineated. It is not disease specific, but can be a useful adjunct to imaging and clinical assessment, or even in patients in the acute stage of the disease. Finally, not to forget about atrial arrhythmias. Atrial involvement is also common in patients with inflammatory cardiomyopathy. Substrate beta ablation due to atrial scarring again remains the strategy of choice. Typically, PV isolation and ablation of the cavotricuspid isthmus are effective. And as with ventricular arrhythmias, outcomes are better when inflammation is controlled. In summary, therefore, granulomatous or non-granulomatous inflammatory cardiomyopathy present with complex arrhythmic substrate, both dynamic and fixed. RFA remains best when inflammation is controlled. The diagnosis of inflammation can be made by either PET or MRI, or increasingly with the use of chitotriosidase. Multimodal management improves outcomes. Multimodal imaging facility help us understand substrate better. In the acute stages, ablation should be the last resort, and especially in patients with VT storm, it should be done after the bilateral cervical sympathectomy. Stable non-inflammatory disease is very amenable to ablation. There is lesser ICD shocks once that is done. Epicardial and mid-myocardial substrates are common. Multiple unstable arrhythmias can be present. Substrate ablation is usually the strategy of choice. Long-term follow-up is essential, and ICD implants are important, especially because disease flare-ups can happen, resulting in ventricular arrhythmias leading to sudden cardiac arrests. Thank you for your patient hearing. This is a list of my collaborators who've helped me prepare this presentation and helped us take care of our patients over the years. Thank you very much for your patient hearing.